I want to be able to look myself in the mirror again, and this is how I'm going to do it.
That's beautiful.
That's how you change hearts.
Yeah.
Ironically, nobody wears the T-shirt of the psych hospital they were at. It does not happen. And that's what happens when you create belonging in healing. And that's very different than this bifurcation of addiction versus mental health. And so how do we, because of our 12-step roots, provide a belonging where in AA language, the only requirement is, a desire to stop drinking.
Welcome back to Mastermind. I'm your host, Mark Scrivner. Our team took the show on the road to NAATP National 2026 to catch up with the leaders, innovators, and voices driving the behavioral health industry forward. We had so many incredible face-to-face sessions on the floor this year, and today we are bringing you one of those dynamic conversations. Let's take a listen. And today we're joined by a very special guest, Dr. Joseph Lee, President and CEO of Hazelden Betty Ford Foundation. It's great to have you on the show. Joe, thanks for being a part of Mastermind. We appreciate it.
Yeah, it's a pleasure to be here, Mark and Jeff. Thanks for having me.
Yeah.
You bet. The first thing that I noticed when you walked up, Joe, is the lapel pin.
Yep.
And it's like, for those of us who know, it's like we instantly know who that is. Would you mind just a little bit of the backstory about what that particular lapel pin is like and how that came to be?
Yeah, this lapel pin is from our 75th anniversary, and it so happened that year the White House decided to commemorate Mrs. Ford's legacy with a stamp. And they put a beautiful painting, and they gave us all these lapels, and we all had the opportunity in the spring of that year to go to the White House, and that wing of the White House is no more, and so it was actually very meaningful now when you look back on it in retrospect, all the history there, and it was just a fabulous event. And I think what the stamp represents for us is this is the true face of recovery. This is what people in recovery look like.
Yes.
I think a lot of times people look at recovery and they kind of look down upon it, even if they're sympathetic to the cause. They see the news stories and the homeless populations and the people who are indigent, and all of those things are true and a part of the picture. But most people in recovery are gainfully employed. They're people out in communities, and they come from all sectors. And so I think Mrs. Ford was a real champion for that. And so she's quite a historical figure in that in the late 70s, she was diagnosed with breast cancer. And I didn't know this at the time, but at that time, I understand that people didn't talk about breast cancer.
There was a stigma around the C word.
Which doesn't even make any sense in today's vernacular, but it was true.
Right.
And she spoke about it.
Right.
And then after that, she had her recovery journey, and she spoke about that. And so I got a chance to give a little speech there. And I talked about how at that time, I still run into people who've met Mrs. Ford maybe once. And they felt so seen by her because her sharing her story, given her stature and place, really made millions of people across the country feel seen for the first time.
When you think about it, back in the 70s, obviously, we every day we work on trying to break the stigma around substance use and mental health. She really did that starting with cancer, and then, she pioneer trailblazer in terms of breaking the stigma, and you're still doing that today.
Yes. Breaking the stigma is a very important part of what we do. And it's not just sharing the story, it's all the things that people need to have legitimate, high-quality, world-class healthcare that's going to break stigma. Outcomes, quality measures, the investment in infrastructure and technology. It's all of those things that make it possible for us to overcome stigma in the end.
Yeah, Joe, you started out as a clinician as we were doing some background on you, and you've moved up to lead like an industry standard setting organization. How did that clinician role set you up for like where you're at today?
Well, a lot of it was accidental. So, when I was in medical school, I wasn't thinking about any kind of a leadership position. I was in medical school, I matched in both internal medicine and in psychiatry. I was thinking of doing hematology, oncology, but I liked cancer stories and the stories of the people more than I did the cancer. So I did psychiatry instead, did my adult psychiatry residency at Duke University, and then did my child and adolescent psychiatry fellowship at Johns Hopkins Hospital. And those were really formative years because those two hospitals and all the great teachers I had taught me the key moments where you lean in and you execute with excellence to deliver world-class healthcare. And when you work in an entity like that, you are kind of given a training on how to deliver that kind of care for people. And so if you are at Johns Hopkins, they have this like little subway-like station where they have a tram that goes from one building to another underground. And on the wall, they have U.S. News and World Report, number one, all the way down to 2.
Right.
And I'll tell you, the doctors that work there, they might be tired, they may have come off call on a shift, but they walk down that corridor with their shoulders up a little bit because they know what they represent. The history of that place was just incredible. And so I think that prepared me when I joined Hazelden. It was before the merger. As a child and adolescent psychiatrist, I was going to get my addiction certification and go back to Maryland and do a private practice. But that training imbued upon me, this is what excellence in healthcare looks like. Mm-hmm. This is how you make patients feel seen. This is how you deliver, the work. Because I was working in inner city Baltimore, and the kids that I was working with there, it was me and the school social worker or the counselor. But these kids and these family members in inner city Baltimore, as far as they were concerned, even though I was a peon, I was a fellow, which is basically a glorified resident. Okay. As far as they were concerned, I was Johns Hopkins Hospital.
Mm-hmm. That's right.
And that ambassadorship and what it means to represent a brand and a mission is something that was really put into my DNA. And I carried that over into Hazelden, a fabulous mission. I came in and then decided to stay, and now I've been with the organization for nearly 18 years.
Amazing.
Yeah.
When you say Hazelden, it comes with the appropriate amount of reverence. I mean, let's face it, the Minnesota model, it is a Mount Rushmore program in our industry. It's past. I'm curious about how you see that past moving into today and then into the future, and then how do you preserve, or do you want to shake up that legacy?
Yeah, I think we have to amplify that legacy. And to understand that legacy, I think you have to go back in time. We started out on a farm in 1949. The name Hazelden comes from the first name of one of the owners of the farm, whose name was Hazel. So it's Hazel's Den.
Yep.
Say Hazelden.
Yep.
Okay? And then this farm changed the trajectory and conversation for addiction in America.
That's right.
Possibly for the world. And the secret sauce of Hazelden before the merger was really, I think, community. It wasn't just about the steps. It was getting people rooted in community in a multidimensional way. And they created recovery communities across the country, across the world, where people would volunteer, partake, and have long-term engagement. And it led to these fabulous outcomes. But long before the Minnesota model, in the 1950s, we were professionalizing the field. We started to publish pamphlets.
That's right.
And literature.
That's right.
In the 1960s, we started to do family treatment. Okay, this is way before Minnesota model. So in many ways, we've always been a pioneer. In when you talk to people in our history, because we have archives, and people will tell you that they didn't think of us as a treatment center, and I think that's the difference. Okay, there's a lot of people in our industry that do treatment. That's what they do. I'd say most people, that's all they do, and that's great. We've always seen ourselves as a social reform movement, and that's different. It is not just about what is the latest bells and whistles. It is, how do we advocate for the field? How do we advocate for the common person who may be dealing with addiction so that a generation later they face less stigma, that they have better parity in their care, and they have better dignity? And that's what our mission's been about. So we continue to innovate. In the 2010s, Suboxone was widely used in the field. It was very controversial in this field, though. As a physician coming in, it was not controversial to me.
Right.
And so there were a number of docs internally. We pushed for the use of Suboxone, but even here in NAATP, it was controversial. Later in the 2010s, we spoke at Congress about the ethics in this industry, because we believe that if we're really going to fight against stigma, our quality has to be top-notch, and we got to stand behind a certain level of integrity in what we deliver. And now we are in this really exciting frontier. And so we do research with Mayo, we do research with Harvard, a number of other institutions try to copy and mimic our research institute, the Butler Center for Research that we have. We've published our outcomes for decades, and that's something that Force has modeled, right, for the industry. And I think the exciting thing about the future is we've standardized our care across the continuum. And that means that wherever you go, we use a common evidence-based curriculum that evolves with patient input. We track metrics. And that foundation allows us to individualize the care. Just to tell you where our field is, when I first went around and said, we're standardizing care, the feedback I got from some of the people in the industry was, well, then how are you going to personalize it?
Right.
And I just want to stop there because that tells you where our field is.
Right.
Because if you go to a hospital,
That's right.
hand washing, standard.
Right.
Right? Certain surgical procedures, standardized. Standardization, ironically, is what leads to personalized, individualized care. I mean, even if you think about it from data and metrics, how can you say that the outcomes are valid if your inputs are all different and random? Right? So it was startling to me when I said, hey, we're going to standardize our curriculum across the country. People were like, how are you going to individualize care? And it's like, and what they were really talking about is, we're not individualizing care across the field. It is arbitrary individualized care, right? Meaning you're baking a loaf of bread, but every single time it's different, and you're calling that individualized.
Right.
You can't really prove outcomes or improve care on a platform like that. So what we've built now is a foundation for personalized medicine, true personalized medicine with standardized inputs, metrics. We have a data lake. We're able to recruit patient data in a way that no real organization can. I think there are some in the industry that are more interested in market share, or, and they have investors that they need to satisfy. And I'm just being very frank here. And I don't know to what degree they can really invest in quality or what their interests are. And then for a lot of nonprofits, they don't have the infrastructure that we do.
Right.
So for us, what's really important is harnessing data, AI, technology, latest innovations to really chart a course towards personalized care. And that's what you're going to see in the future. So we're going to continue to push, we're going to continue to innovate, and we're going to continue to raise the bar for, I think, what people should demand from good addiction care.
Yeah. Since we're at NAATP and you're on the board, what are the industry leaders concerned about this year? What are some of the big topics that you all are discussing?
I think everybody, us included, we're all concerned about the things that impact us. Medicaid cuts, changes in government grant programs that really impacted our publishing department.
Yes.
Reimbursement rates, all those proximal operational things, and it is a challenge to stay visionary and missional while you're trying to maintain all of those kind of business stakes. But it's very important that we still keep our rudder and maintain our integrity on why we entered this field, and the quality work that we do. Otherwise we're putting the cart in front of the horse.
Yeah, I mean, you speak aspirationally, and as you should. I mean, there's a ton that you should be proud of and a ton of things that you want, but it's there are some practical realities here. So it's how does an organization the size of Hazelden and Betty Ford do both? How do you walk and chew gum at the same time?
It's funny. It doesn't matter how big an organization is. When you talk to Fortune 100 companies, they have the exact same dilemma.
Right. That's true. That's true.
So every company feels stretched thin at all times in multiple directions. But I actually think there's tremendous value in what we offer. So if you go back to, now we didn't start a graduate school because it was going to make money. We didn't do a family and children's program because it was going to make money. We didn't do a Butler Center for Research or a publishing arm because it was going to make money. We all did it because, again, we were a social reform movement, okay? We wanted to change hearts. We wanted to professionalize the field. We recognized that people adjacent to the people in care needed help. And so I actually think it's not just aspiration. Right now, we have the ability to leverage our enterprise to provide value to all kinds of stakeholders. I'll just give you a couple of examples. Our graduate school produces counselors that are both trained to deliver SUD and mental health. It's asynchronous. People can do their 9-to-5 job. So in this industry, one of the pain points is supply chain of talent. I mean, we have a homegrown enterprise supply chain of talent. That is an enterprise advantage that we have. And we also did something that I think was incredibly cool. One day, Kevin Doyle, the grad school CEO, came to me and he said, Joe, did you know that you don't need a bachelor's degree to get a master's degree? And I was like, get out of here. Okay. Here I am with all my shingles,
right,
and
exactly.
It's like, what? And
it does not compute.
But it's true. And so we wanted the rigor, right? We wanted the rigor to recruit people who could do graduate school. We called this program the Alternate Admissions Program. And so we created a program where people apply. It's a rigorous program. And we graduated the first cohort of around 5 people, and some are still on their way to graduating. And the stories of these people, it's really the story of recovery. A lot of these people
are these paraprofessionals or
these people may be tech second career people, but
okay.
I think if you think about
GED at least, right? Or,
yeah, definitely, but they don't have a bachelor's.
Okay, yep.
Okay, and so these individuals are people who may have lost some years because of their recovery journey. They may be from communities that may not have the resources to get that education, and so we've been able to create this program, and then we have like a feedback loop with loan forgiveness and loan repayment. So that's one example of an enterprise play.
Yeah.
I'll give you another example of an enterprise play is our publishing arm.
Mm-hmm.
You saw in the award ceremony yesterday, we publish a lot of things.
Absolutely.
And we firepower the industry. Mm-hmm. So not everything has to be the patients we treat. And so we partner with ASAM. We publish their adult ASAM criteria. It's been great for them. It's been great for the industry. It's been great for standardizing the field and keeping with the spirit of what we talked about. And this year we just published the teen and transitional youth criteria for ASAM, and that's going to go out. So that's another partnership and an ability to get out there. And in the world of AI, creating legitimate content that people trust. And we want to be able to lend our seal of approval to say, we have a publishing arm. We've had a publishing arm for decades.
Right.
And you can trust the content that we put out there to disseminate best training and practices. And even our co-occurring curriculum that we standardized throughout the country was a collaboration between publishing, our Butler Center for Research, and our clinical arm. So yes, there are many pressures. Yes, there are many things going on. But we actually, in this era of AI and technology, have, I think, incredible opportunities to leverage those enterprise assets in an accelerated way.
Yeah, the educational arm is very interesting. Do you have universities across the nation come to you to take part in your curriculum, or are they asking you to help them build their own curriculum?
We have partnerships with a number of different universities. We don't yet build curriculum for them, but we have a number of different partnerships. And I would love to get into Native American communities, and maybe those communities only have an associate's level program, and they are struggling to have the firepower to build their own clinics. And they don't want people to come in from the outside and run a clinic. They want to own the clinic. They want to own the solution. And why shouldn't they?
Right.
Yeah.
And if you think about our curriculum, our graduate school, the way we count data with our research and our publishing arm, we can port these products to a community where we don't have to be the primary treaters. You see, they don't have to come to residential care at the Betty Ford Center in Center City. We can help arm them with the necessary tools that are based on data and scientific to start their own clinics. And so I actually think there's tremendous opportunity because of technology to port some of the products that we've developed missionally in a way that can help a lot of people.
Yeah.
I'm really curious. I'm just going to ask this question. I have no idea how you're going to answer it because I'm fascinated. Changing hearts, right? What is the metric for measuring the changing of hearts? Because that is a lovely and aspirational goal, and I think it's one of the reasons we're all in the field. How do you measure that, Joe?
I would say there are, metrics that show, and they're lagging, so they tell you afterwards,
right?
What it is. And then there are some leading indicators like therapeutic rapport that lead to changing hearts. So there are proximal and down the road kind of psychometric features that correlate to a change of heart. And it depends on the audience. So you have a patient who may be very ambivalent about their substance use. And so we know that patient and we know how to get change. Believe it or not, we are a proud 12-step oriented program, but I'm a motivational interviewing trainer, and we actually have 8 or 9 motivational interviewing trainers, more than any other organization, and it really enhances the 12 steps. Okay, it helps you. The point is to help change hearts,
right?
Yeah.
And we add these questions, and it's a little bit of a secret sauce on our front end. We ask some questions to elicit the change of heart. And I'll just give you an example because it was in an email thread. Okay, anonymous, no patient private information. But we added this question to the end of the questionnaire And the patient's response to the question, which I'm not going to tell you what it is was, I want to be able to look myself in the mirror again. And this is how I'm going to do it.
Wow.
That's beautiful.
That's how you change hearts.
Yeah.
So you build the setup for that. And it's one of those things I learned at Johns Hopkins and other places. And I was the medical director at a youth site for a long time. And there are these peak experiences, and people talk about them at Disney. You have peak experiences. And you have to know that excellent healthcare really isn't just about the latest gadgets or, psychedelics or GLPs. All those things are important. All the innovations are important. But it's really about what you do in these key moments and interactions and the questions you ask and how you pull solutions out of people. And I do think it's measurable, but it's not like one question, like, did your heart change?
Right.
You see it in their motivation, you see it in their commitment, you see it in their rapport, and you see it in their engagement.
Fantastic answer.
Yeah.
Definitely put you on the spot on that one. So
No,
I appreciate
yeah,
that.
I love it.
I'm curious, from your vantage point, where do you think our industry is in terms of being recognized for delivering quality health care? And I think you know what I mean by that when I'm asking the question.
I think we have a ways to go. To be empathetic to our industry, we were cut out of mainstream healthcare.
That's right.
Right? And so I think there's
Did
only...
we do the cutting or did
No, somebody else did the cutting.
Okay.
People did not want us in healthcare. And many mainstream hospitals really, from a dollars and cents perspective, still don't want us.
Right.
Right? And so when you have a group of an industry that grew up marginalized without resources, you can only finger point so much to
get a
say
little
you
bit
should
of
have
an
done
attitude,
better.
right?
Yeah, well, I mean, if you cut people out from society and they kind of have to form their own, group, and then you criticize them later for not having the same civic infrastructure, I mean, that criticism only goes so far.
There's entire novels written about it.
Yes. That said, to take some accountability as an industry, I think we have a ways to go because I think to really crush stigma, we have to be able to deliver healthcare on par, the outcomes, the quality, the whole bit, with the rest of mainstream healthcare. And I think when that day comes, then we will have legitimacy in the same way that other healthcare specialties have. And I think we're making a number of bold steps, and every decade there's advancements. But we have a ways to go. And I think, Hazelden Betty Ford, it's complementary, and many people say you guys are the gold standard in the field. And to us, what that means is not just being the best. It means we have to be the standard bearer for what treatment means and what people deserve, and what their families deserve. And that's something that we try to hold ourselves up to.
Yeah, outside of your organization, what trends are you seeing? I know you talked about, the Medicare, Medicaid component, but like just in care, what trends are you seeing that maybe concern you the most?
I think they're actually exciting trends. Now, what may be concerning is how different stakeholders will leverage those things. Okay, and I'll explain what I mean. But I think the advent of new medications are exciting. I think studying neurophysiology, neuromodulation is exciting. So some of the research partnerships that we have drumming out, we see thousands of patients. So the ability for us to recruit and gather data, and we want to in the future, because we're renovating the Betty Ford Center starting this year. And as we do that, I definitely want an innovation hub there. I want an innovation hub in Center City because there's so many patients and so many research partners that want our data and they want to partner. And so all the novel treatments that you hear about, I think we're going to be able to plug in and get some personalized data on who responds to those things. So that's super exciting. I think AI is super exciting. Because we're now a very data-driven, all of a sudden, this data that we couldn't mine, and it was buried in Excel spreadsheets and all this stuff, now is in a data lake, and that changes everything, and it gives us a different kind of purview of how to personalize care and deliver good care. So all of that is exciting. I think the thing that I'm cautious about in healthcare, I would say innovations and technology in general are used to amplify current treatment. I think because of stigma in behavioral healthcare, okay, not mainstream healthcare, in behavioral healthcare, I think technology and innovation is often used to replace the care.
Yes.
That's a big difference.
Yes.
You know, so instead of like helping a internal medicine doc with their note and their documentation, in mental health, it's almost like you don't need a therapist. Just talk to this AI agent. It's a different line in the sand. And I think we have to be cautious about how it's used, because if we aren't clear about the drivers and the stigma that surrounds it, and then I think internally as an industry, we have to be careful that we're not all bells and whistles and style over substance. And I think that's a critique of the industry that I've long held. And you've seen it, right? And and there have been many iterations of it. You know, people try to compete with swimming pools and amenities. People try to compete with, you know, animal therapy. I mean, right?
Right.
And now it's the latest and greatest treatments that they say they deliver, but they don't have the data to back up. I mean, so I think on our side too, on the industry, we have to make sure that there's a certain standard. I'll give you an example. Is when we did the youth and young adult criteria for ASAM. Our youth residential side and our outpatient continuum, our youth continuum, we meet all the standards. You know, we do family therapy, we have siblings programs, we have not just a family program, we have family services that are parallel to the patient all the way through coaching, virtual services, we have educational products. Yeah, we have triple boarded child psychiatrists, we have addiction medicine docs that are pediatricians, we have psychologists, we have, you know, motivational interviewing training. We got this stuff. But you see that an unregulated or less regulated youth industry is coming under a lot of fire.
Right.
And there's truth in what is happening. You know, a lot of wilderness programs, a lot of, you know, therapeutic boarding schools that didn't have the same rigor. And what we're hoping to do is use something like the ASAM criteria to say, this is how you are supposed to do it. This is a hard industry to be in, but as you help young people, these are the kinds of things that they need. These are the kinds of supports that families need. This is how you integrate back into the communities and the schools. And so there are things that concern me, but I think there's a way back, and we have a number of case examples to make sure that the standard remains high.
What do you think is the best mechanism to, it's like, so we've identified, yes, there's a big gap there, right?
Yep.
Is it trade organizations? Is it, I mean, you know, obviously Hazelden Betty Ford, you can't do all this work, obviously, even though you may want to.
Right.
What's the right way to actually bring up some of the players that need to come up to your standard?
I think it's leveraging our intellectual property. It's leveraging partnerships. You know, we've always believed in the things that we do will, you know, be the rising tide that lifts all boats. I mean, that's kind of what we've always believed in. We think that's what the ASAM criteria is. We think that's what standardizing care is. As we start to innovate and we start to dabble into new medications or GLPs or neuromodulation things, we're going to do it the right way. And you're going to see that it's going to lift the whole field, and we're not going to be the only ones who benefit. We want everybody to benefit, and we want to be in communities. And so our goal isn't to put a clinic in every neighborhood in America. Our goal is to really lift all boats and make sure that anyone who is getting treatment for addiction and related mental health services are really getting the best dignified care.
Yeah, you know, just staying back on the AI, I can't imagine the amount of data that you all had. And I guess, what was there an aha moment? Like, what kind of things did you start to discover once you synthesized all of that data? Was there any aha moments of, wow?
Yeah. You know, data science is ongoing and it's hard. So I don't want to say that it's all completely done. Just because you have a data lake and stuff, there's a lot of intricacies in how you set up the data infrastructure. Okay, so we're not all the way there yet, but we're close. And there are some really interesting findings that we see in the data. It's now in its second year. We used a DDCAT, you know, dual diagnosis capability assessment, you know, tool. I think that's what it stands for. We publish it, by the way.
The DDCAT. Yep. That's right.
We train it and publish it.
That's right.
And it was really designed to make sure that providers who were providing addiction care also had commensurate mental health care. And you're either going to do a parallel play mental health, or you're going to do like an integrated mental health. And notice that the language in the ASAM criteria is now like, co-occurring is like the standard, right? It is not the exception.
It's the expectation.
That's the expectation.
Yeah, that's right.
So we looked at some of this criteria, and we built a unit, and there's 2 units in Center City that are integrated mental health. Okay, so all of our patients get co-occurring national standardized care, but this is like even more integrated than the others. Okay, and what we found in our data is that those patients are more engaged. They are actually less likely to atypically discharge. So the things that you wouldn't expect, because people complain about acuity and the mental health, but those patients actually stay longer, are more appreciative of the help, you know what I mean, are measuring us on fidelity. So these are the things that we find through our data mining, that we're actually providing great value for these patients in a way that I think is very different, because I think in the mental health world, some of these patients that are complicated and get help, they don't get the kind of belonging that a recovery community provides. And then the recovery communities don't provide the evidence-based skill sets.
Well, that's almost exactly where I was going to go with the question. It's like, with an organization so deeply rooted in the 12-step tradition, right? How comfortable is that overlap still within your organization in terms of 12-step and then mental health? Because you just spoke to exactly where I was going to go. It's like, how that's experienced.
Well, like I said, being a child psychiatrist and motivational interviewing trainer, so when I was at our youth campus and I was the medical director, I used to tell parents I'm like an Italian restaurant. Everything's family style, right? Everything's family style,
right?
And I would work with the young person, and then I would call the parents, and we'd talk for like 30 minutes to an hour, and I give them coaching on da 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 da. And then when you get on the phone tonight, I want you to say da 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 da. And then I tell the patient the same thing, and I would do their medications, and I would do their Suboxone, and I would treat their ADHD. So I have this belief that's not. It's not a hypothesis. I know that good integrated care can be delivered. I know what it looks like. I know what it feels like. And so I have a commitment to that. And so I think right now, the way that the medical model delivers behavioral health care, the medical model is great, but it's really designed for appendectomies. It's really designed for antibiotics for pneumonia.
Right.
Yeah.
It is not designed for long-term, reciprocal, community-involved kind of healing that recovery often needs.
Right.
And before you even get to recovery, I'd say because of that, the medical model struggles with things like diabetes, because it's not this procedural,
right. It's this chronic, ongoing.
Yes, that requires a back and forth. It requires patient accountability and volunteerism. It requires a back and forth. And so I think there's as we offer these co-occurring services, what we find is that these patients find the best of both worlds, that they're getting the evidence-based skills they need, but they also feel like they belong, and they have skin in the game, not only in their own welfare, but in the welfare of others, which then actually helps promote their own welfare. And in many ways, it is the 12-step principles kind of broken down, and kind of lived out and manifest. And so, and then we see it in the data, and it's just an incredible thing. And I gave a speech once, and I say it now here and again, but one thing that's very interesting about Hazelden Betty Ford is our patients wear our swag. Okay?
I see it at airports.
Our patients wear our sweaters.
Yep.
They wear our hats. They wear our T-shirts. They wear the T-shirt of the unit that they were on that nobody else in the world would know, but they're proud of it because they belong. And ironically, nobody wears the T-shirt of the psych hospital they were at. It does not happen. And that's what happens when you create belonging in healing. And that's very different than this bifurcation of addiction versus mental health. And so how do we, because there are 12-step roots, provide a belonging where in AA language the only requirement is, a desire to stop drinking. But a little broader is, hey, if you want to be included and you're looking for help, we have a place for you. And I think that sense of belonging is something that is structurally missing in how care is delivered and reimbursed today. And it is a fundamental tenet of what we believe in and how people heal.
Yeah.
When you look at some of the medical advancements that are taking place, and I love having an MD. What are you seeing as most promising? I mean, you mentioned GLP. I'm fascinated about what that might yield. What are you seeing and that you love?
I think there are a number of advancements. I think neuromodulation is very, and that's TMS, but it's also low frequency ultrasound. It goes to deep brain stimulation. GLPs are very exciting, and there's tons of studies now. Veterans Hospital Administration. And so, and I think all of them are going to be important tools. It should be noted that there's a lot of hype around tools,
right,
and then it kind of settles out,
right.
So I remember when ketamine hit the market initially.
Listen, tools are the easy thing to talk about, right?
Well, I mean, it's just all human behaviors go to convenience, right? So it's a and so of course there's that quick fix kind of thing, but I think if it's again used to amplify and not replace, all of these things are very exciting and can help, and there's things that you have to solve for. How do we get people to stay on GLPs? Is it because of cost? Is it? And then there's side effects that people didn't talk about initially, but now are discussing. So, and I think that's with a lot of medications. We talked about ketamine, but any kind of medication. I think even using certain psychedelics or hallucinogens for depression. The initial refractory studies were very promising. Later studies, a little bit more mixed in their results. And I think you got to let the science evolve, and we want to be a part of that science. And again, we're building the foundation so that, in the future, we're able to collect data in such a way that we're not just going to be able to say, does a particular intervention work? We're going to be able to say, what kinds of people respond to this kind of intervention, which is a completely different kind of question.
Yeah, man, this has been such a fabulous episode. I'm so uplifted. It's obvious how passionate you are about the business. I guess as you look back over your tenure, what is something that you're the most proud of?
If you look at our 77-year history now, and I've always said, I'm a steward of the mission. It's not my company, it's not my mission.
Yeah.
And so some of the things I'm really proud of, the integration of mental health is something that I think historically is a gift to the mission that will pay dividends. Our desire to help more communities, okay? And the alternate admissions tool. So a lot of people talk about it, but we actually built a tool where, how many times do people have within generation opportunity to change their lives and their trajectory and to help others? It's not often. And so I'm very proud of that. I'm proud of the operational system we built and the data and the infrastructure and the enterprise ecosystem that is now ready to go. So I could go on and on, but there's a lot of things that I think that we've done that advance our outcomes and our quality of care and further establish the field. And but we're just getting started.
That's amazing. How about 3 years out?
Yeah.
What are you the most excited about?
I was just in the talk this morning in this kind of future back.
Yeah.
And this is going to sound so old school, but it goes back to, because I'm actually a very simple thinker. Because I think those are the things that scale. And when I look at the research studies and the Cochrane Review for why Alcoholics Anonymous is helpful, it goes back again to this community and connection and the sense of belonging. But not just that. It's not a unidirectional thing. Volunteerism is critical. They have to partake. You see what I'm saying? They have to partake in it. And it's a simple concept. So 3 years from now, though, I think if technology drives a community, eventually consumerism and differentiation take hold, and it is a farce of a community. It is not a community. It actually takes you away from a community, but pretends to be a community. So, like standard social media. Right? Everyone's trying to be a different avatar.
So shots fired at Instagram influencers out there.
Well, it's just, I think it is when you say you're trying to create a community, but the root cause is you want people to purchase things to be different than other people.
Right.
Fundamentally, it's hard definitionally have a community.
Right.
Because you're actually encouraging everybody to be performative.
Right, exactly.
But if we can have technology be subservient to the core community principles, 3 years from now, how do we amplify that feeling of belonging? And so whether it's residential or outpatient or virtual or through technology, or actually the flywheel of all of those things included, can we create that kind of belonging and community? And that would be super exciting for me.
Yeah. Is there anything, as we wrap up, is there anything maybe we didn't ask you or that you want to share that you think will help the audience?
Oh, I could go down the rabbit hole on a lot of topics, as you all know. But, I just think that people get better. People get better in recovery, and that's what the research shows. A lot of people get short-sighted and they get stuck on, the treatment failed, or the ups and downs of it. And I don't think we talk that way when a diabetic's blood sugar goes high, or you know what I mean, or maybe they didn't adhere to their diet like they should have. And I think there's still a pejorative lens. And I think we are very passionate about continuing to show the outcomes and quality, because our mission is really fueled by those people who are so transformed by the healing that they had that they spend the rest of their lives trying to help other people do the same. And that really is the flywheel of recovery. And I want people to understand that's where all the passion in our mission comes from. And I think our field has shown basic outcomes, like that what we do roughly works. Data's not great, but just as a whole. And then I think we've landed on some really innovative bells and whistles. But I think the future is really personalized care, but not losing sight of some of those community aspects that really make healing possible.
Yeah. I love the way that you say that, it's the simple ideas that really scale. And just one thing I'd love to share with you is that I think enthusiasm and optimism scales too, and you have that in abundance. So thank you so much for that. I mean, really appreciate you bringing that, and our industry, should thank you for that level of encouragement.
Well, I think in recovery we appreciate gratitude.
Yes.
And you just have to talk to. I do this thing called patient rounding. I talk to random patients at our campuses. I don't tell them. I don't wear a suit. So I have my name tag.
This is just conference uniform.
and I just say I'm Joe. Okay, I'm on the team. I want to ask you some questions, and I always ask them, what's your name, and then I say, what's going well, what can we do better, how come you chose us, kind of these standard questions. And it is amazing how these patients resonate. And the number one thing they say is they talk about community. They talk about how they belong. They talk about how everybody treats them with dignity, and that's a very special feeling. And you can do, you can cut this way or that way, and you can do all the evidence-based care, but those are cultural elements that are very special to a recovery community that I think when people try to replicate what we do, that's actually the secret sauce of it. It's that feeling, and I'll kind of close on this. I had a young person I was eating lunch with at a family program in our youth site, and he had just graduated high school, and he just in lunch, random conversation, he says, I lost a lot of my formative high school years because of the pandemic, he said. And then randomly he said, being in treatment is the first time that I've experienced community in my life.
Wow.
And it was both profound and incredibly sad.
Yes.
But it also really highlighted the value
and
we bring people,
too.
Because I think we live in a society that is kind of a satire of connection. People are very lonely, and we are technologically connected. And I'm not pinning the tail on the donkey on social media alone. Okay, I think, but we have a problem of disconnect in our society, and I think we as a field have a lot more to offer than just getting off of drugs and alcohol.
Yeah, Joe, thank you so much for everything you're doing for the industry. Your collaborative mindset is really creating the community that we need. And we really appreciate you being a part of the Mastermind podcast and everything you've shared today. We're going to drop your information in the show notes just because I know a lot of people will want to learn more and maybe even want to reach out. So we appreciate you being a part of it, and we'll see you all next week on Mastermind.
That wraps up this episode of Mastermind. Thank you so much for joining us. And remember, Mastermind is not just a podcast, it's a community. So don't forget to comment, subscribe, and review us. Your feedback helps us continue to bring you content that's relevant and relatable. Thanks again to our sponsor, Snapshot, a digital media marketing agency. And thank you for joining us on Mastermind, your behavioral health playbook.